Now we thought we could request one of our Indian colleague, Dr. Johann Christopher. We're happy that we were together, and he was junior to us. And when he was taking his career decision, I advised him probably to go for cardiac CT and this sort of nuclear subspecialty, which would be better rather than again running in this rat race of PCI. I think now he's a renowned figure in our country. I'm happy to say that he's a considered authority in cardiac imaging in our country. I'm very happy Dr. Johann agreed to this, and Dr. Sharmila also agreed to involve one of the few doctors from India. With this intro, I request Dr. Johann to show some case examples on the similar topics where how nuclear cardiology made decision making easy and helpful to patients. Over to you, Johann.
Good evening, esteemed faculty. Special thanks to Dr. Srinivas Kumar and also Dr. Durbala for really mentoring me in the United States. And I think that was a defining moment in my career. So a big thank you to both of you. And I'll be just presenting a few cases from our own lab to just give you a flavor of what happens in our country. As we know, the goal of treatment in coronary artery disease is to increase event-free survival, to improve LV function, and relief from anginal symptoms. And one of the important decision-making is to see whether revascularization versus medical management is the way to go forward. And in our nuclear lab, we have the stress rest, we do the RNVs and also the PET scan. The two SPECT traces that we do are sestimobie and tetraphosphamine. We don't do thallium in our lab. Now, the gatekeeper, especially in the Indian scenario, has been now for the last decade. If the patient has no prior event and it is a screening, then the patient gets a CT angio. And if there is significant disease, directly goes to the cath lab. And if it's borderline, they undergo a stress myocardial perfusion. And if the ischemia is significant, they would go for the catheter angio. Also, if the patient already had an angiogram and if there is a borderline stenosis, you would do the MPI and then move to catheter angio. So also, if the patient has a severe LV dysfunction, they would have the NTG-gated, NTG-augmented REST scan or a PET scan if it was available. But these are all developments that has happened over the last 5 to 8 years, while previously it was only the catheter angio that was being used. In view of time, straight away plunging into the case, this is a 72-year-old male. He's hypertensive diabetic, new onset of shortness of breath. We thought it was anginal equivalent. Vitals were stable, slightly higher blood pressure, good LV function. The ECG showed a LVH, and this is the angiogram. You can see this is the AP cranial view. You can see that the mid-LAD has a borderline segment. There is diagonal disease as well. The RCA was normal and the L6 had mild disease. So after this, what next? Remember, we were not very clear about the angina. There was shortness of breath. So in this situation, when we have a intermediate lesion, we went ahead and did the stress maybe, and as convention is, we have the stress and the rest scan, short axis, the vertical long axis, and the horizontal long axis. And this was the polar map showing a virtually identical stress and rest perfusion map. The volumetry showed a good LV function. There was no transient ischemic dilatation, and the ejection fraction was preserved. So we believe that there was no significant inducible ischemia. Patient was kept on optimal medical therapy and on close follow-up. So the question here, and my intervention colleagues did ask me, is are we right in concluding that this patient is safe? Incidentally, for similar symptoms, the patient did undergo a nuclear scan in 2016, about 4 years ago, prior to the present scan, and the picture was similar. You can see the small fixed perfusion defect in the infralateral wall, and patient was kept on medical management at that time, showing you the robustness of the technique. And if you look at the data that is available, clearly if the quantification of ischemia is less than 10% with a good LV function, the event-free survival is excellent. Hence, the patient was kept on optimal medical management, and we know we have excellent drugs today to deal with that. The second case is a hypertensive and diabetic patient. He's 52 years old. He had a prior stenting to the LAD in 2016. Recent onset shortness of breath, TMT was done positive at 5.5 mets, and the clinical exam was no heart failure, normal vitals, and his echocardiogram showed a regional wall motion abnormality with a mild LV dysfunction. The angiogram was performed as expected, and here you can clearly see that at the stent there is a CTO at the level of the diagonal, first diagonal. The rest of the vessels are normal. Now, where do we go from here? So, one of the important roles of myocardial perfusion scan is the adequacy of collateral flow. And we did the myocardial perfusion scan. You can see the stress images, short axis, normalization and rest, the vertical long axis, horizontal long axis, and the polar map clearly showing you a large reversible perfusion defect in the LAD territory. The rest was absolutely normal and also viable, suggesting that this patient had a large stress-inducible ischemia in the LAD territory with adequate viability. There was also transient ischemic dilatation, which is a high-risk marker. And if you look at the data from Dan Berman's group, you can clearly see that this patient was an optimal candidate for a revascularization, either a CTO PCI or a Lima mid-cap surgery, which would be a sort of a semi-invasive kind of surgery for this patient. The third case is a 35-year-old gentleman, no conventional risk factors, recent onset shortness of breath. He was intermediate risk in terms of his Framingham risk score. Vitals were stable, structurally normal heart. We did the CT as a first line investigation, as I told you. When there's no prior problems, we do the CTA, and clearly you can clearly see here, this is the RCA. You can see the RCS coming from the left sinus, and here it is on the VRTs. This is the left main LAD and the left circumflex, and the RCS coming from the left sinus, and it's coursing in with an interarterial course between the aorta and the pulmonary artery. There is an angulation, but the orifice seems to be normal. So in our center, if this patient, we check whether he's truly malignant. And we go ahead with the nuclear scan, and this patient did a good exercise, and this is his slices, the stress, rest, and the polar map, completely normal. He did about 10 mets. The volumetry again showed a normal ejection fraction. There was no TID or stress-induced LV dysfunction, and hence this patient was kept on lifestyle modification. He was kept on a beta blocker. No surgery was planned, neither a bypass to the RCA nor a translocation of the coronary, and this patient did very well over a 5-year period. Case number 4 is a 58-year-old male. He's hypertensive diabetic, had an anti-wall MI about a month ago, did not get any revasc done, came with worsening shortness of breath. The echo showed severe LV dysfunction, and he was sent by one of our primary physicians for revascularization. Again, you can clearly see there's an ostial total LAD occlusion. Rest of the vessels were normal. And as Dr. Dirbala has clearly beautifully shown us the reason why we do viability, and we have multiple techniques, each with their own specificities and sensitivities. We went ahead with the nuclear scan, and that's we used adenosine in this patient. You can see the stress, rest, and the polar map again showing you almost a fixed effect, a large scar, transmural, and a non-transmural scar in the LAD territory with a severe LV dysfunction and a dilated left ventricle. And as you have already heard, that each technique has its own merits and demerits, but in this particular case, with a fixed perfusion defect and no stress-induced ischemia with the vasodilated stress, the patient was kept on optimal medical therapy, and with this large scar burden, we were planning to go ahead as per the mandate 2 criteria for an ICT. Case number 5 is a hypertensive diabetic, recent angina, referred for angiogram, wall motion, the RCA, good LV function, and here it is, it's a CTO in the mid RCA, went ahead, did the nuclear scan, stress, rest, and you can see here the polar map again showing you a scar in the RCA territory with a moderate LV dysfunction. There was no peri-infarct ischemia, so this patient was kept on optimal medical therapy. Case number 5 is a lady with shortness of breath, heart failure medication, severe LV dysfunction. Again, as you can see, a long segment, total occlusion of the LAD. In this case, we did a PET scan, and as per protocol, this is the perfusion map. We use a MIBI in our lab, because we don't have ammonia or rubidium, and you can see the large perfusion defect here in the anterior inferior septum. There is FDG uptake in the same segments as you can see, and therefore this patient with a severe LV dysfunction, large perfusion defect, but significant FDG uptake had a significant viability in the LAD territory and was taken up for a PCI to LAD. So these were the cases. I just want to thank all of you, and we have progressed a lot. And I've had the unique opportunity to work with Dr. Durbala and her team, and I think I have become a better person, if not a better cardiologist. Thank you very much for your patience here. Thank you.
Yeah, and thank you, Johan. I thought you will show 3 cases, but you showed much more, and multidynamic, both for all types of modalities you showed examples.